Okay, next question. Hi, Doc and Dave. Great show. Incredibly informative and helpful. Is nandrolone decanoate healing powered gym lore or real science? There's a study from NC University suggesting that there might be something to it. They were rotator cuff surgery patients. Thank you.
Okay, this is a tricky one. This is about gym lore versus real science, and I think it's somewhat of an antinomy because the points aren't being made properly, and there's a little bit of crossover that's misleading. Meaning, does it heal? In this case, with a rotator cuff tear, rotator cuff, it's 4 different muscles. So if you've got a tear in the muscle, then yes, having something anabolic is great to have on board to help you heal the muscle tissue. Duh, right? But what I hear mostly attached to the use of nandrolone, or as we used to call it by its brand name, decaduralan, is, oh boy, I have arthritic pain, and boy, all I gotta do is take some Dec and it heals my joints. No, it doesn't. Okay? Now, to segue from what I first said here about helping with shoulder muscles, the rotator cuff muscles, but also some of the others, it can help with joint pain if you use it for its ability, and I'll circle back to this in a second, to reduce pain and then allow you to do the exercises you need to do to, for example, reposition the shoulder joint so it doesn't rub on that nub of the glenoid or the humerus that's missing some cartilage. You can reposition a little bit. Remember, the shoulder joint is unique, and we call it a joint, but it's really a stick stuck up there, and actually there's a little place where it sort of rubs, if you will, but it's connected with a bunch of duct tape, ligaments, tendons, and these muscles that hold it into place. And the muscles are no small part of holding it into place. So if you can reposition the shoulder or make it more stable, if you can't even reposition it that much, then you're in good stead, and you can accelerate that process by using any anabolic, but particularly nandrolone, again, because it also has a property that it's a NOR19 testosterone. It's a unique one, the way it's built, the molecule. And whether it's it's one of the progestins that can be metabolized into, and it has a pretty extensive first pass metabolism in the liver. But I believe the consensus is that it's not the active sites that are being affected. They're like the androgen receptor sites. It's the production and the activation of corticosteroid metabolites that help ease pain. It's like I'm getting an anabolic shot as well as a cortisone shot all in one, so that you reduce inflammation, and the end result of that is that you don't feel the pain. So people think they're on a shoulder healing drug, nandrolone, but they're not. And so what I see, unfortunately, often is guys will feel better. The corticosteroid or whatever effect from the metabolites of the progestins that are formed from nandrolone make people feel better. They think the shoulder's healed, and they go for PBs, personal bests. Yeah. And then they're worse than they ever were when they come off of this again.
It's a masking.
And I've seen it happen. Yeah, it's a masking agent. Actually, great way to put it. And so I tell people, do not use nandrolone if you think it's curing your shoulder joint pain. Yeah. Use it to bring your pain down to a level. It's really a 2-for-1, and also, do your teres minor exercise if it's appropriate to reposition the shoulder so that you don't aggravate an existing injury. So did that make sense to you? Okay, so I mean that's a short and sweet question. That's
nice.
That's where it has its magic, but it's masking the pain. Thank you for putting it that way. Yeah. It ain't healing things except in the indirect way to which I refer.
Awesome. Thanks, Doc.
Yeah, well,
okay, Doc, what do you got next?
I say that, I read the first. Hi, Dr. McLean. I love your YouTube channel. Well, thank you. First of all, it's not mine. This was all, I've said this before, all Big Dave's idea.
It's ours.
You're evidently a great doctor. Well, thank you very much for saying so. It's yet to be seen. My question is roughly around hair loss and my abnormal estrogen levels. I am 30 years old, male, 5'9", 170 pounds in shape, and eat healthfully. I began losing my hair due to Dermatologist confirmed male pattern baldness around age 25. I did not treat the male pattern baldness until around age 29, when the hair loss got to an untenable stage. I became aware of finasteride and had some blood tests done prior to starting the finasteride. My results were as follows. Total test was 882 nanograms per deciliter. Free test was 172 picograms per milliliter. Estradiol was 49 picograms per milliliter, and SHBG was 1176 nanograms per deciliter. I realized that my estrogen was above range, and I had 4 follow-up tests done over 4 months that reconfirmed these levels. I was hesitant to start finasteride, and I was aware of the fact that it would raise my estradiol levels by a further 15% or so, and would exacerbate my high estradiol symptoms, slightly depressed, moody, and water retention. My endocrinologist tested and ruled out any tumors that could be the cause of high normal test and above range estradiol. In November 2016, I decided to start finasteride, 1 milligram every other day, and after 1 month noted a significant difference in hair fall rate, and after 4 months noted my hair was beginning to thicken up. I also noted that I had slightly worse symptoms of moodiness and water retention. I asked my endocrinologist about possible ways to reduce my estrogen, and he suggested letrozole, 2.5 milligrams twice a week. I thought that Arimidex and the low dosage to start off with would have been a better option, but he assured me that the letrozole was the better option. 2 weeks in, I was feeling much better mood-wise and had no water retention issues at all, but my hair began to fall out like crazy. I upped my finasteride dosage to 1 milligram per day after the 2 weeks on letrozole. My blood tests after 6 weeks of letrozole usage were as follows. Total test was 1,718 nanograms per deciliter. Wow. Free test was 324 picograms per milliliter, and estradiol was 11 picograms per milliliter. SHBG was 1,712 nanograms per deciliter. The letrozole had a dramatic impact on my test and estrogen, but my hair loss continued. I continued the letrozole for another 2 weeks, at which point the hair fall became untenable and I had more than reversed the gains made from finasteride. My hair fall has continued for 2 weeks post cessation of letrozole despite continuation of finasteride 1 milligram per day. We're not even getting to the questions till now.
My question is...
Okay, first of all, I mean, before I even get to the questions, because I got to scroll back up and I don't want to keep scrolling back and forth. These numbers are kind of odd numbers to begin with. I mean, the first group of test scores or assays look pretty odd to me. To have a free T, well, maybe this is from, I don't know what lab this is from, but that's not as bad actually as the second round. I mean, to have a total test of over 1,000 at this age, in other words, have it as 1718 nanograms per deciliter total test without taking the testosterone, this is pretty phenomenal. And of course the free T is commensurately high, but normal in the sense that the percentage is about the same. But letrozole is always a poor choice in my opinion. It's a last choice. Letrozole was the first drug, the first aromatase inhibitor invented, and then because of some liver enzyme elevations, which were mild, okay, but still, if you can come up with a better drug, meaning one that doesn't cause any liver enzyme elevations, well then we go for it. We developed anastrozole, and anastrozole has been the drug of choice from the get-go because of that. Now, letrozole is way more powerful than anastrozole, and it has side effects that they don't necessarily talk about. it can bring the estrogen levels down exactly to the same point as an anastrozole can, but with side effects. And most of those side effects are usually erectile dysfunction.
Oh boy.
And you go, well, yeah, of course, because it over suppresses the estrogen, so you can have a problem. But again, as I said, I will see the same estrogen assays as I would with an anastrozole, but when using letrozole, for whatever reason, in my clinical experience, you have big issues with letrozole. So I save letrozole for big problems of estrogen. I will tell a typical user of anabolics that is using so much, is a perfect example of what you don't do, right? That you're using drugs to control the drugs, right?
Mm-hmm.
So that their estrogen's out of control, in other words, and they can't bring their estrogen under control using an anastrozole. Then, okay, you move to letrozole. But it's definitely a last resort for not just the liver, but also for the, trying to avoid the side effects. But he made another comment about he was worried about, okay, I was aware of the fact that it would raise my estrogen levels by starting finasteride. Yes, it could indirectly, because remember, finasteride is just blocking the conversion. It's a 5-alpha reductase inhibitor, blocking the conversion from testosterone into dihydrotestosterone. Now, if you do that, then yes, conceivably, then your testosterone's higher, and that, instead of going to dihydrotestosterone, can go to estrogen. That is true. But it's not something you necessarily go, oh, this is definitely going to happen. But let's see, did he say it that way? I was wondering. Yeah, it would raise his
by 15%.
Estradiol. Yeah, that's definitely possible. Looking for tumors, I don't know what the purpose of, and I don't want to second guess any doctor, so I'm just saying, my endocrinologist tested and ruled out any tumors that could be the cause of high normal testosterone and above range estradiol. Yeah, okay, sorry, I misread that. Yeah, because those T levels are fantastically high, right?
Wow.
For natural.
Yeah.
So, okay, he's probably looking for what's called a pituitary, typically a microadenoma, which is a non-cancerous tumor, typically, that grows on that little stalk, the pituitary, which is right above the roof of your mouth, that can make your pituitary do strange things, produce too little or too less. It's usually too little of luteinizing hormone. In this case, maybe it's too high luteinizing hormone causing the elevation. I don't understand why he's having problems with hair loss, except for when you start messing around with your hormones, and this doesn't happen that often, it's relatively rare, broad stroke, and you see some big swings, then you can start losing hair because of a shock to the system is a good way to put it, just in layman's terms. The hormonal shock of such a big change. I've had it happen, and unfortunately happened to one of my patients who was a hairdresser.
Oh,
and he started noticing some hair loss. I didn't notice anything, but hairdresser, I'm sure he noticed, I'm sure it was real. And one of the worst things you can do is then drop everything. I mean, he punted the whole TRT program, and he was about 50 years old. And that makes it even worse, because then you have a reverse swing the opposite way, and then it can exacerbate the problems. The best thing you do is stay the course, and if you're going to make any changes, gradually makes those changes so you don't shock the system any more than you have. I'd say it's happened to fewer than 5 people in 16,000 patients, right? Okay, the questions. Those were just my comments. Now we have the question. Firstly, what are the possible reasons I have high normal tests coupled with a naturally high level of estrogen in the first place? No idea. Again,
gifted.
Yeah, lucky. But the first thing I would look to is, as the endocrinologist suggested, I give an MRI of the head and see if, or particularly the pituitary, and see what's going on. But of course, you know that you have high tests. Body likes ratios, but even just standard chemistry. Stoichiometry, X plus Y equals Z, as long as Y is not a limiting factor. You add more X, you're going to get more Z. We know testosterone is a substrate from which estrogen is made, so you got more T, you're going to probably have more E, right? So that part I can answer. Is my hair loss due to the hormonal change? Oh, here he says it right here, sorry. Is my hair loss due to the hormonal change shock while on letrozole? Could be that. It could be the effect of not only letrozole, but maybe something else that needs to be investigated, pituitary microadenoma. And he calls it, the name is telogen effluvium. Well, that's not necessarily what, well, it's one way you could lose hair. Okay, fair enough. Not necessarily the name I would give this hormonal change shock, but anyway. I should continue treatment on letrozole or wait it out. Okay, again, I just answered that without knowing it was coming. Letrozole, that's a good question though. I would change it gradually, and what you could do is you could start to wean off of letrozole and go on to anastrozole, or wait maybe as much as 3 months to let your body get to unshock itself, if you will, as long as you don't have any side effects from the letrozole. That one's kind of obvious. But if you do start to have side effects from letrozole that are, as he puts it, untenable, other than the hair problems, then you start to switch them out, but trying not to affect the estrogen levels. Or do you believe the rise in tests was met with a rise in DHT, especially scalp DHT, and compounded by the absence of protective qualities of estrogen on my follicles? And if so, should I expect the finasteride to regain effectiveness once my hormones return to baseline? Too much guesswork in that. We don't know, and I'm not sure we would go to we could always go to whatever extent you would want to do to look at the numbers, but more than likely, the best thing to do here is to switch to a different 5-alpha reductase inhibitor. Finasteride works great on 2 of the receptors. Dutasteride includes the third, and it's the one that's more localized at the hair follicle, at the prostate gland. So again, this is curbside service medicine here, but assuming that everything else levels out, maybe do it after the 3 months, and we have hurdled the hormonal change shock aspect of this, then I would change from finasteride to dutasteride, just because it works better overall than does finasteride. And incidentally, I would always start with finasteride. I'd ask your doctor if you want to use a 5-alpha reductase inhibitor, start with finasteride because it has a shorter half-life. And if for any reason you have the rare, despite what you read on the internet, the rare side effects while on TRT taking finasteride, then you can get off finasteride, and typically within 2 to 3 weeks tops, everything symptom-wise will resolve and you're not stuck with something. Whereas with dutasteride, which has a 5-week half-life, you're stuck with it once you start it. So you start with finasteride, you go, hey, it's working well, and if it's working well, then don't change what's not broken, but say it's working well, but it could work better, then switch to dutasteride, right? Finally, would you recommend that, hopefully once I control the hair loss, I look at Arimidex at a much lower dose to bring my estrogen down to an acceptable level? Okay, I already answered that one. Apologies for the length of the background of questions. I understand you cannot give medical advice to this platform. Thank you for understanding that. But any insight would be highly appreciated. Thank you very much for your consideration, Doc. Warm regards from South Africa, Mikola or Mykola. All right, did I answer everything?
Yeah, that was great. Boy, he was very thorough.
Yeah, well, that was a good one. Like a consultation almost. That kind of detail, yeah.
I'm a smart watcher. Thanks, Doc.